it. I believe everybody should see that. Let's see. Yes. All right. So again, I'm Dr. Mbwana. I'm going to be doing this child neurology shadowing session today. Bit of an outline about how I'm going to structure the presentation. I'll just talk a little bit about me, a bit about child neurology and what it means to become a child neurologist. Briefly, I'll chat about my journey to medicine just to kind of give you my background, and then we'll go into a case. And at the end of it, I'll summarize with some teaching points, and we'll be open for questions. If you have any questions sort of as we're going along, go ahead and ask them. I'll be looking in the chat box. But at the end, I'll make sure to give some time as well to have any kind of questions, or if there's any that I didn't get to during the presentation, we'll do the questions then. I always like to put these disclaimers. The case discussed here is fictional, not based on anything real. I'm doing this in my private capacity, and so the views here are completely only mine. And there's no conflicts of interest or financial interests here with this presentation. All right, so a bit about me. As you already heard, I went to college at Yale University and then followed that up with medical school at the Morehouse School of Medicine. I did my pediatrics residency at Yale New Haven Hospital and then child neurology training at the Children's Hospital of Philadelphia. And now I'm a child neurology attending at Children's National Hospital. And that also has me sort of listed as faculty assistant professor at George Washington School of Medicine. And that's in neurology and pediatrics. So child neurology is pretty much the same as pediatric neurology. It's kind of just two different names, the same thing, and encompasses any disorders of the brain, spinal cord, peripheral nerves, or muscles affecting infants, children, and adolescents. So important to know that we don't just deal with the brain, and we deal with everyone from the moment of birth all the way until they're technically 18, but I have patients up until 25 years old or so. To become a pediatric neurologist, you have to do 2 years of pediatric residency, followed by 1 year of adult neurology, and then 2 years of child neurology. Most people, especially these days, will do all 5 years at a single institution. And when they're applying for their residency spots, that's what they're applying. They're applying to one institution to complete the whole child neurology training. When I did it, it was slightly different and I ended up doing 3 years of pediatrics at one institution and then went to do the 1 year of adult neurology and 2 years child neurology at a separate institution. Child neurologists are certified through the American Board of Psychiatry and Neurology. And it's just with a special qualification in child neurology. What that essentially means is that child neurologists are neurologists who can see adults and children, but we've specialized further so that we choose to see children only. And it's an important distinction because even though we are not technically pediatricians because we're not boarded through the American Board of Pediatrics, we still consider ourselves pediatricians since we have substantial training in pediatrics. Some of the conditions that we see are listed here, and I kind of try to separate them out where the ones to the left are things that I'll more likely see in the clinic, and the ones to the right are things that I'll more likely see in the hospital. So things like headaches, seizures, concussions, tics, Tourette's, I see those a lot in the clinic. They're kind of like the top things. And when I'm working on the pediatric wards or the ICU, that's when I get some of the things like stroke, meningitis, which is infection or inflammation of the brain, and those sorts of things. My general journey to medicine. So before college, I had a general interest in becoming a doctor, but didn't necessarily have any shadowing or medical experiences. When I joined college, I decided to major in biomedical engineering, but I still went ahead and completed all pre-med requirements at the same time. I didn't have the opportunity to do any shadowing or have any sort of extra medical experiences just because of my schedule. But I did go ahead and take the MCAT my senior year, and that was more so because that's something which kind of everybody was doing, and so I kind of felt like the right thing to do. Applied to 4 medical schools and didn't get in. And so I went to work at a neuroimaging facility because I'd already developed an interest in neurology. I did that for 3 years working as a research assistant. that gave me the opportunity to work with pediatric patients with epilepsy and autism. I also had the opportunity to shadow some physicians. And towards the end of the 3 years, I redid the MCAT, and that was mostly because when you're applying to medical schools, they need an MCAT score within the prior 3 years. So I reapplied and was accepted to Morehouse School of Medicine. And from there on, I did the medical school residency fellowship, and now here I am as an attending. All right, so now moving on to the case. How I like to think about the case is think about it as if you really were shadowing. And so for now, we'll imagine that we're in the clinic setting, just my regular outpatient clinic. And we have a patient who's coming in, an 8-year-old, and the chief complaint is that she's having problems concentrating and is doing poorly in school. All right, so what is the first step that we do when you have someone coming in with this complaint? The first thing we do, not just as neurologists, but as physicians, is to build a differential diagnosis list. So to build a differential diagnosis list, what you essentially do is consider all possible causes for the symptoms. And you're mostly kind of doing this in your mind. And then when you kind of have that list kind of built, you think about which causes are the most common, therefore the most likely to be what it is. But at the same time, you also have to consider which of the possible causes are the most critical and potentially life-threatening that you would not want to miss, and therefore you'd want to rule them out sooner rather than later. All right, so for this 8-year-old girl who's having problems concentrating and doing poorly in school, what are some things that you think should be listed on the differential? Just anything that comes to mind. All right, a couple of people are saying ADHD, so attention deficit hyperactivity disorder. That's a possibility. Anything else someone would think about for someone not doing well in school?
Problems at home.
Yep, could be some problems at home, kind of like social stressors, learning disability, definitely, and sleep problems. Yep, depression, anxiety, so kind of more psychological or psychiatric issues. All those are really great. And these are the kind of things where when you kind of see the chief complaint in the chart before entering the patient's room, you kind of have this running list of things that you're considering, and that'll kind of direct the questions that you'll ask at that point. All right, so here's some of the things that I would think of as kind of high on my list that you mentioned. So attention deficit hyperactivity disorder, attention deficit disorder. The main difference between with the being that with ADD you don't necessarily have hyperactivity. Learning disability is another one. It could just be that's the student. Or it could also be inattentiveness. Some people are just really way inattentive, where it's not to the point of ADD or ADHD, but they just can't focus or concentrate. And really important when we talk about the inattentiveness, that could be due to some of the things that you guys mentioned, including social stressors or problems at home or problems sleeping. Basically, there's something in the background that's making them more inattentive than they otherwise would be. All right, so a couple of people mentioned ADHD, attention deficit hyperactivity disorder. So let's talk about what exactly that is and how you diagnose it. So we'll know sort of what questions to ask or what things to look for when we go in to see the patient. So the key clinical features are hyperactivity and impulsivity. And so a real inability to sit still, someone who's kind of always fidgeting. There's going to be some inattention with the reduced ability to focus and reduced cognitive processing and responding. So someone who, you kind of tell that you have to repeat things multiple times. Really important is there has to be impaired functioning, meaning this hyperactivity and inattention has to affect their schoolwork, if it's someone who's working in a job, their work, their employment. Basically, it has to be to that degree that it's affecting things. Otherwise, you would not call it a disorder. The specific diagnostic criteria include that the symptoms have to occur often, and they also have to happen in more than one setting. So it's not just at school, but at home, they're displaying the same thing. It has to have been present for at least 6 months, and has to be present before the age of 12 years. Really important to note that this doesn't mean that it necessarily has to have been diagnosed at 12 years old. It could be that, let's say you have a 15-year-old or a 20-year-old and they're coming in for the assessment, but they're describing symptoms that began prior to the age of 12, then you can still make this diagnosis. And that's an important sort of distinction, because we consider ADHD to be something that someone is genetically predisposed towards having. So it's not something that develops in your later years. Symptoms can become a bit more apparent in your later years, but this is something where we'd expect, if it truly is ADHD or ADD, you had symptoms from the time you were a child. As previously mentioned, there has to be impaired function in academic, social, or occupational settings, and it has to be excessive for the developmental level of a child. You know, a 2-year-old or a 3-year-old, of course, they're going to be a bit hyperactive and inattentive. That's appropriate for their age level, but an 8-year-old, you expect them to be behaving differently. So you always want to consider that developmental level. How we diagnose it is we use behavior rating scale. So it's not just something where you kind of hear the history and just kind of get a general feeling that someone is inattentive, but rather you have structured observations of behavior, which it's a series of questions that are asked, and they're usually kind of rated. And it's filled by both the parents as well as the teachers, because you want to know that these are things that are being seen both at home as well as in school. And then you compare the results of the two, and they have to kind of score equally, or at least significantly, in both settings. The most common behavior rating scale we use is called the Vanderbilt, and that goes all across all pediatricians, neurologists, psychiatrists, psychologists. That's the one that we generally tend to use for the diagnosis of ADHD or ADD. All right, so now going back along to the case with this girl. So we've walked in and we've started seeing her. And the history that is given is that she typically has been getting all A's and completes all classwork, but over the past year has gotten mostly C's. She has difficulty completing homework, and she gets frustrated both in class as well as at home doing the homework. The teachers also say she's often paying attention or daydreaming, and at home her parents say she forgets to do her chores or doesn't do them completely. When you think about her past medical history, family history, and social history, all non-contributory. There's nothing different or significant there. Her vital signs are completely within normal range. And as far as her exam, generally speaking, it's completely normal as noted there. Those are all the different things that we did. All right, so just as a review, we've kind of heard her history, and we know what to look for ADHD, which I think was kind of highest on the list so far of what we have. So looking now back at this differential diagnosis list that we had built, what are people thinking? What are we settling on something now? Let's see. Anyone want to step up and say what they, if this was in the clinic and we're shadowing, they asked you, what is the diagnosis here? What would you say? All right, well, let's see. I'm going to go ahead and say that I think most people at this point, given the history and given the description of what we know so far, that it would be pointing towards ADD. There's no hyperactivity that's necessarily been mentioned, but there is some problem with inattentiveness, and it really does seem to be impacting the schoolwork over the past year. And this is something which appears to not only be affecting school, but also at home with the chores. So this would seem to fit a diagnosis of ADD. So what we would do is we would give the parents this is the Vanderbilt assessment scale I was talking about. So you'd have it, you'd give the parents, usually do 3 copies. So one will be filled by the parents, and then 2 to be filled by 2 different teachers. And the reason for doing 2 different teachers is because, you don't want any kind of bias from one teacher. You kind of want to get a global assessment. And hope you can see the kind of questions that are asked on the Vanderbilt. So do they pay attention to details or make mistakes that seem careless? And the choices are never, occasionally, often, or very often. Or do they not seem to listen when spoken to directly? And again, same thing. They can say never, occasionally, often, very often, just kind of going along with that, and you end up scoring it. So we're pointing towards ADD in this case. Of course, there's going to be more. That's not it, right? This is child neurology shadowing. It would be too easy and too quick if that's what it was, because that's something which would, that would just kind of cut it close. So there's a bit more to this story. So you have given the parents the Vanderbilt forms and they're about to leave. And then all of a sudden they're like, the child's mother asks, just by the way, as part of what we've noticed, she sometimes gets so zoned out that she almost walked into traffic and almost sort of walked into a wall. That's how zoned out she could get, just to try and confirm that we're still thinking the same thing. So now that's a new bit of information we have to think of with, to add on top of everything that's been said so far. Let's revisit the differential diagnosis. In addition to everything that was talked about, we now have this kind of concerning symptom that someone who's 8 years old, who should know better, almost walked into traffic. That's how inattentive they got. What are people thinking? Is there anything else that we can add to this differential? Anything else that we should consider? Or are we still good with the Vanderbilt form? Just kind of give it to them and wait and see what happens when they bring them back. In my mind, I can already think of one or two other things, but I want to see what you guys can come up with. All right, I'll give this one to you guys because it is a bit tricky. It could potentially be seizures. That's one thing that I would think of if I hear of anyone who's had such a loss of awareness that they really almost did something like walk into traffic or, bumped into a wall or something of that sort. So let's talk about seizures so we can properly understand the context of what we're hearing. So a seizure is the clinical expression of abnormal or excessive synchronous discharges of neurons, or what I just like to say, it's abnormal electrical brainwave activity. We all have electrical brainwave activity. That's how the different parts of the brain communicate with each other. But if anything happens to disrupt that normal flow of electricity, that's when you get the physical symptoms of a seizure. Epilepsy is a condition in which someone has multiple seizures or at risk of having multiple seizures. That's a very important distinction. And the way I like to think of it is a seizure is like a sneeze. It's a symptom. It's just something someone does. Whereas epilepsy is like the flu. So someone who has the flu might sneeze a lot. So someone who has epilepsy has a lot of seizures. So that's just sort of the definition. And if you think about diagnostic clues, things that can make you think or at least consider of seizures in the differential, uh, seizure will typically have a loss of awareness that's sudden onset, and so it doesn't seem to creep up on someone, just kind of all of a sudden comes on. There's increased or decreased muscle tone, so they either stiffen up like this or stiffen up like this, or they just sort of lose tone and fall. There is typically, but not always, abnormal movements, and the abnormal movements can be kind of like jerking movements like this, or can be just one hand or more shaking like that. And there's typically an alteration of mental status after the event. That's because after you have this disruption of electrical activity, then as the brain is recovering, someone might be a bit more sleepy, talk slower, and there's usually a history of prior similar events. Of course, when someone's had their first seizure, there's not going to be a history, but if someone's had repeated seizures, then you expect to hear a history of events that sound exactly similar. And the way we diagnose seizures, in addition to the history, is to do an EEG, an electroencephalogram, where we put electrodes on their scalp and we measure their electrical brainwave activity for about 30 minutes or an hour. And that's because people who are having seizures or who have epilepsy are likely to have abnormal background activity during this time. So some questions here. Are there other medical conditions that cause seizures besides epilepsy? Uh, Yes, so there are medical conditions that can cause seizures, and we kind of make a distinction between uh, what we call provoked seizures and unprovoked seizures. So if you have a medical condition, such as a traumatic brain injury or an infection of the brain that causes seizures, we call those provoked seizures because the seizures were caused by something external. And so in that case, they do not have epilepsy. On the other hand, unprovoked seizures are the ones that just sort of come up out of the blue. And so if someone is having unprovoked seizures, we would call that epilepsy. Someone else is asking, would all patients have jerking movements because this patient didn't? Yes, it's possible to have seizures without jerking movements. So the diagnostic clues that I mentioned on this slide, uh, those aren't things that everyone has to have. Those are just things that kind of clue you in. So a lot of people will have seizures without abnormal movements or without a change in muscle tone or without loss of awareness. It can sort of be sort of a mix and match. And I should say we do see seizures and epilepsy as neurologists quite often. It's one of the more common things that we see patients for. Now, there's a very specific type of seizures called absence seizures, leading to absence epilepsy, which we tend to think of as neurologists when the chief complaint is someone who seems to be zoning out. So with absence epilepsy, the pattern of abnormality in the brain is very, very specific. And what it leads to and what you see is someone who has impaired consciousness and completely unaware of what's happening around them, even though they have no change in muscle tone. So they don't fall. They kind of, if they're sitting listening, they just will continue sitting right there. Uh, they can last anywhere from 1 to 2 seconds to up to 30 seconds. And the person having it is completely unaware that they had a seizure or there was a loss of time. So it's not like when you're sleepy and you kind of, notice yourself drowsy and, sort of waking up. When someone goes in and out of an absence seizure, they have no idea anything happened, except they might notice that they missed a sentence or two. That might kind of give them a clue. Again, there's no falling or stiffening. And it may be accompanied by eye, mouth, or finger movement. So it can be some rapid blinking, some movement with their mouth, or some movements with their fingers, kind of like a rolling pill movement. And really importantly, if someone has an absence seizure while they're standing, they remain standing. If they have an absence seizure while doing something like walking, they will actually continue walking, except that they'll walk they might walk in circles, walk into a wall, walk into kind of with no direction because they have no awareness of what they are doing. We uh, diagnostic clues that are specific for absence seizures include staring episodes, so where someone seems to be staring and zoned out and you can't get their attention. They can start having poor school performance, and that's primarily because if you're in school and you're sitting, but you're having a seizure, an absence seizure every 10 or 15 minutes, you're missing bits of information and you don't know that you're missing information. The teacher doesn't know you're missing information. And when it comes time for the test, you just are getting questions wrong and you have no idea why. They may have episodes of abnormal walking. And really importantly, episodes can be triggered by hyperventilation. And so sometimes in the clinic, when I see a patient with a suspicion for absence seizures, I have them do some breathing exercises where I put something in front of their face and tell them to kind of blow. And after a minute or two, you may witness them having the seizure. And again, the diagnostic tool here is the electroencephalogram. And when we do it, we see a pattern that's very specific for absence seizures. It's what we call a 3 hertz spike and wave pattern. All right. And all right, so now looking back at this patient, so there's two things we can do to kind of help us with this diagnosis. The first is doing the hyperventilation in clinic, which I'll often do when the suspicion level is there. You usually do it for about 3 minutes at the most. If they've not had a seizure within 3 minutes, then I'll stop. Not everyone who has absence seizures will have that hyperventilation, but I'll say at least half of them or so do. And if they do, then at least kind of lets me know. I'll probably still, or I'll say I'll definitely still do the EEG because you want that sort of confirmation. But if they had the seizure due to hyperventilation, then at least that way I can start medication sooner rather than later. So in this case, for this patient, we went ahead and did that, and they had the loss of awareness evoked by the hyperventilation, and the EEG showed that classic 3 hertz spike and wave that we talked about. Therefore, the diagnosis that we settle on is the childhood absence epilepsy. We started this patient on treatment, and we use a medicine called ethosuximide, which is an anti-seizure medication which works only for absence seizures, but it's actually the best one for absence seizures. They started it twice a day at the appropriate age and weight dose. And when they came back for a follow-up, they noted that there were no more seizures or stirring episodes after 2 weeks. Their academic performance and home life had improved. All the deficits that were being noted had resolved. And a repeat EEG done in 3 months was now completely normal, showing that the seizures or risk of seizures had resolved by that time. One of the things that we always tell parents about childhood absence epilepsy is compared to other forms of epilepsy, it has a much higher likelihood of outgrowing them. 77 to 90% of children diagnosed with childhood absence epilepsy stop having seizures by adolescence, so probably by around 13 or 14 years old. Completely stops. You can get them off of medication and they don't have any recurrence of seizures, and they have no sort of increased risk of developing epilepsy later on in life. There is, however, that 10 to 25% who will continue to have seizures, absence seizures through adolescence, and they might even develop other seizure types like the generalized tonic-clonic, where you have a loss of consciousness with the rhythmic jerking, and that may last for the rest of their lives at that point. All right, any questions about the case so far, absence seizures, or anything of what we've talked about? All right, some of the key principles I'd like to emphasize with any case, or the approach that we use in neurology, is that it's really, really important to develop a broad differential diagnosis list, then narrow it down appropriately. That's what's going to get you everything. And you kind of go through the steps which I mentioned, which is that you think of the most common things. And so like with this patient, the most common reason for that presentation would have been ADHD. And then you think about narrowing it down. And you narrow it down by eliminating things. And some of the important ones to eliminate are things that are more critical, such as seizures. And so we'd narrow it down doing the hyperventilation in the clinic and then the EEG. Secondly, it's really important in neurology to do what we call localizing the lesion, or identifying the level of structure with an abnormality. In this case, for someone who comes in with sort of a behavioral thing like not doing well in school, then you already sort of localize that to the brain. But if it was something else like weakness, for example, you'd have to think about, is this a problem with the brain? Is it a problem with the nerves, the spine, the muscles? And so we always do that as a neurology teaching point. And also, very importantly, it's really important to repeat a history or exam when needed. Let's say this child, the parent had not mentioned that additional information about almost walking into a wall, and they went home with the Vanderbilt form, and they came back 2 weeks later, and you looked at it, and it didn't fit with the diagnosis of ADHD, or it fit with the diagnosis of ADHD, and you started ADHD medication, and they did not get better. Then you definitely want to repeat the history and exam to see if there's any points that you missed, or to try and get more detail. And I think for most clinicians, and definitely most neurologists, they'll say that a diagnosis was made sort of on the second go around when you were kind of repeating things. Someone asks, when testing for epilepsy, is it easy to rule out other conditions? It depends on what the other conditions are. In a lot of cases, you kind of do what we call a stepwise assessment. So if someone was coming in with, let's say, spells of change in muscle tone, and they're also having abnormal behavior, such as saying things that don't make sense, then different things that we would think about would be if it could be meningitis, so infection of the brain causing that, if it could be seizures, like in this case, causing that, if it could be a primary psychiatric diagnosis. And so the kind of stepwise thing we do is we may start with the EEG and look at the results. If it gives us the answer that it's seizures, that's what it is. If it doesn't, then we move on to the next thing. We do a brain MRI to see, could this be like a tumor or something like that? And if that gives us the result, we stop there. If not, we move on to the next thing, maybe doing a spinal tap to look and see if there are signs of inflammation or infection. And if there is, then we kind of stop there. If not, we kind of keep going along. So it really depends on what other conditions you're concerned about. But I should say that epilepsy it tends to be, if you have the suspicion for it, somewhat easier to rule out because the EEG is very diagnostic for it. Sometimes you might not get an answer with the short 30-minute EEG. And then we do what we call an overnight EEG, where someone comes to the hospital and we record for almost 24 hours. And that almost always gives us a diagnosis. Any other questions about anything we've talked about? All right, to close it out, I'll just mention, a personal teaching point that I always like to give, and I give these points, is that it's important to make your journey to medicine your own, because the journey is just as important as the destination. In all my medical training, and even right now as an attending, I see people who've gotten to where they are through all sorts of different paths. I have a colleague in medical school who was in the Marines for many years, and it's after he left the Marines, I think it was close to 40 or 45, and he joined medical school because he wanted to be a physician, and now he's like a really great emergency department physician. I have others who worked in private industry, others who are lawyers, and of course you have people who went kind of straight through from college to medical school, and for each one, they really benefited from whatever path they chose. And so for you, whatever stage you're in and whatever your journey will be, you kind of have to make sure that you benefit from each step going forward. All right, thank you everybody for attending, and thank you so much for this opportunity. We love teaching, and I'm always glad to get the opportunity to do that.
Thank you so much for hosting our event today. It was truly inspiring.